Hi, I'm Lisa Fortier from the Cornell University College of Veterinary Medicine. Today, we're going to do nanoneedle standing arthroscopy of the right medial femorotibial joint. We're using the Arthrex NanoScope system and the new nanoneedle. This client horse has been diagnosed with stifle arthritis based on radiographs. Our goal today is to get a really good view of the cartilage and meniscus in order to provide a prognosis for the owner and to perform any manipulations as needed. Let's get started. The horse has been bathed and sedated, and the operation sites have been clipped. All three joint compartments have been blocked with regional anesthesia. Our entry portal is between the middle and the lateral patellar ligaments. So right now I'm going to put a skin bleb with local anesthetic and then we'll get started. Here I'm palpating the middle patellar ligament. So that makes this medial and this is lateral. The point of entry is right between these two ligaments. For equine standing arthroscopy, it's really important to have the high-flow cannula set along with the nanoneedle, which we will hook up in a minute, and then our setup is complete with a few other specific nano instruments. This horse has extensive stifle effusion, so we're not going to need the fluid pump. Rather, we're going to use a 60 cc syringe and extension set. That results in less people in your operating room, less fluids, less cost, and it's more efficient. The cannulas for the nanoneedle come as straight or with a 10-degree curve. I prefer the 10-degree curve for every equine arthroscopy I do so that you can see over trochlear ridges and around grooves and corners. If you use this sharp trocar, you do not need to make a skin incision, but the sharp trocar doesn't conform to the bend of the curved cannula. So in order to use the curved cannula and the soft obturator, a small skin and joint capsule incision are required to introduce the nanoneedle. The setup with the needle scope is very simple. I simply hand over the end that goes into the console to the OR technician and leave the tip on for calibration. The surgeon calibrates the system by pushing any button on the handpiece. Remember to leave the black cap with the red tag on. Be sure to keep this black cap if you want to reuse the nanoneedle or you will not be able to recalibrate the system. Okay, so we're back palpating the middle and lateral patellar ligaments. The entry portal is between these two ligaments and about 2 centimeters above the tibial crest. Again, because we're using the curved cannula, we will make a small skin and joint capsule incision and guide the cannula directly into the medial femorotibial joint. The obturator is then removed, and because the obturator has a daminate located just proximal to the lure lock, fluid will not come out of the cannula when the obturator is removed as it does with a standard arthroscopic sheath. It's really handy to hook up a 3-way stopcock and a short extension set to have someone outside of the surgical field assist with fluid distension. Now to the right of the screen is the axial aspect of the medial femoral condyle. You can see that it's devoid of articular cartilage. The meniscus is at the bottom of the screen. A key with standing arthroscopy in the horse is to be sure that you have a constant flow of fluid to maintain visualization. The tibia with the meniscus is below. And remember, this horse is completely weight-bearing, so we might get a better view if we can get her in a slightly flexed position. There's the axial aspect of the medial femoral condyle, again devoid of articular cartilage. Remember, when you're using the nanoneedle, that the rotational view comes from the cannula. Your view will not change by rotating the needle. Down on the bottom of the screen is the meniscus again. Top is the medial femoral condyle. We're getting a really nice view of the condyle. And you can see just as the assistant is about to refill the fluid, we start to lose visualization. If you're going to be here for a while and perform many manipulations, it's nice to use a pump. There's the medial side of the medial femoral condyle at the 3 o'clock position in the screen. Coming back to the axial side of the medial femoral condyle on the top of the screen over at 9 o'clock and the tibial plateau in the center of the screen. Down at 6 o'clock is where we would go deep into the joint if we can get her to flex. So again, at 9 o'clock is the axial side of the medial femoral condyle. You can see an osteophyte in the cranial tibial plateau at the very bottom of the screen. We're not able to see the cartilage on the tibial plateau, indicating we have a degenerate meniscus. The dorsal rim of the medial condyle is covered with an osteophyte. You can see a change to the more chalky-looking articular cartilage. There's a large concavity in the medial femoral condyle where it should be nice and smooth and round. So it's abnormal in shape, plus it's lost its articular cartilage. Note the hyperemia of the synovial membrane, clearly indicating an arthritic joint with thickening of the synovial membrane as well. So we've just repositioned the horse ever so slightly to get her less weight-bearing and flex this stifle. We could put her in a Kimsey splint if needed, but this is more of a simple diagnostic arthroscopy at this point. Again, medial femoral condyle on the top. We're getting a deeper view into the joint, and you can see a very large horizontal laceration in the articular cartilage, the medial femoral condyle on the top of the screen. There's that large crevice on the medial femoral condyle, and now we're looking down at the meniscus. It is very degenerate. That's the medial aspect of the intercondylar eminence, which should be the attachment of the meniscal tibial ligament. We see a large osteophyte running vertically from 11 o'clock to the 7 o'clock position, which is off the edge of the axial side of the medial femoral condyle. This horse's prognosis with the articular cartilage loss, chondromalacia, as well as the degenerate meniscus is very poor for any type of performance. However, use of the nanoneedle in standing arthroscopy provided an accurate assessment of the meniscus and the articular cartilage above what could be provided with diagnostic imaging and without the risks and costs associated with general anesthesia. Thank you for watching.